afternoon, everyone. Thank you for being participating on our annual conference here at NAMI, California. We are honored to have here Dr. Nisha Warikoo, and she is an MD and is founder and director of Monarch Psychiatry of California. She is an award-winning board-certified child, adolescent, and adult psychiatrist. Dr. Warikoo is known for her thorough diagnostic approach across various stages of development, as well as the ability to provide compassionate, evidence-based, and well-rounded treatment for patients and families she sees. Her areas of expertise include depression, anxiety, ADHD, and autism. She is affiliated with the Community Hospital of San Bernardino County and provides inpatient and emergency care services to those presenting mental health concerns. Dr. Warikoo also is a volunteer clinical faculty at UCI and is passionate about teaching and training residents and fellows. The floor is yours. Thank you, Dr. Warikoo.
Good afternoon, everyone. I did the same talk last year, but it was certainly very different. I could see the audience, I could interact with them in real time, but times are certainly different, and I appreciate the opportunity to do the same this year, even though in a different setting. So we're gonna try to make the most of it, and to make the flow easier, I have been given a list of questions that all of you had submitted based on a poll, and these are the questions that came up. Since the presentation is an hour long, only an hour long, I will first go through these questions that were generated based on a poll, and you're welcome to raise your hand or send messages through the app if you have any follow-up questions to those initial questions, and I will address. And if certainly there's some time left towards the end of the presentation, I'll be happy to take on more questions. So without further ado, I will start with the first question, that is it common for people with mental illness to decide not to have children? So that is a very interesting question. There is no clear data or research studies that have actually shown what is the percentage of patients or people with mental illness who decide to have children or do not decide to have children. But certainly based on clinical experience, we see it both ways. Sometimes patients with mental illness may decide to have children, and they may decide to have children sooner than our typical population due to having certain risky impulsive behaviors during some of the episodes, for example, bipolar mania, ADHD, substance abuse. All of these conditions are associated with having earlier pregnancies and having kids sooner. On the other hand, there may be a fair proportion of mentally ill people who are not able to function and have so many negative symptoms. By negative symptoms, I mean so many deficits in motivation, self-care, ability to take care of activities of daily living, that they're not able to function at a level where they will find someone or meet someone and decide to have children. So we've seen both scenarios. They may have children more and sooner, or they may not have children. So I don't think there is kind of higher probability of one or the other happening, and it is dependent on case by case basis. Any questions about that? All right, I know we are in a weird setting where we are not able to interact, but we could ask questions through the WOA app or send it in the chat window, and we will do our best to facilitate this. The second question is about why do doctors not listen to parents who know their children best and know they need help? So it seems like this question may have come from somebody who has not had a very positive experience with mental health providers. I do think that it is very important for doctors to listen and be very open and empathic towards all of the families who are bringing their children and adolescents to seek mental health care. They are recognizing certain things and certain symptoms. They're recognizing these symptoms are getting in the way, and they're taking the next step, which can be a very hard step for families to do, to bring their child to mental health care and to seek diagnosis and treatment. Sometimes, depending upon the fit between the provider and the patient and the family, there may be times where they are not seeing eye to eye, or they are not able to do a good job explaining the diagnosis and the treatment recommendations. And even more than that, what is most important is to meet the family where they are. The family may have sought just diagnoses and they may not be ready for initiating treatment, because what happens is a lot of people do their research before they see a psychiatrist. And when they do their research, they might be relying on Google to do their research. And a lot of times when you Google different things, it will tell you a lot of bad things about a lot of medications, a lot of treatments, a lot of diagnoses. So sometimes more than help, it may do harm, because it might actually delay help seeking. So I do believe that it is important for providers and physicians to do a good job educating the families, because they are the ones in that role. They are the ones who have the expertise, and so they have the responsibility to educate the families about the diagnoses, about the best treatment options out there, about the current research and the treatment guidelines. But at the same time, meet the families where they are, meet them, and not come across as if they're not listening to the families or they're trying to push treatment. That should certainly not be the goal. Sometimes just connecting with a healthcare provider can be helpful, and initiating step one of treatment, maybe therapy, may be important, and monitoring for any worsening and signs for when a medication treatment is necessary. So I do think that if there are times where you're getting a feeling that you sought this doctor out, you met with them, you had the whole evaluation, but you're feeling that they're not listening to you, or you're feeling kind of dismissed, then you have to bring it up to them. You have to bring it up to them and say, this is what I'm feeling. And I know it's important for me and my family to feel connected to the healthcare provider, feel like we are being understood. And despite that, if you feel like they're not getting it, or they're not able to fall into that middle zone with you, meet you where you are, then it's okay to seek a second opinion. The most important thing is having a trusting and good therapeutic relationship with your physician. That is a very important thing that determines how the treatment is going to affect the child and the family as a whole. Any questions about that? Okay. So moving on to the third question, how can we help them realize they can lead normal lives and that it's okay to be on meds? That is a very important question. All of these questions are really important, and especially this one. Sometimes kids as little as 6 years old, 7 years old, 8-year-old kids need to be on medications. And it is because the symptoms of the condition are at a level where therapy alone is not going to help, and they're really getting in the way of life. So it's important to explain for both the family and the physician who's treating the patient and the child that this is what the condition is and this is what the medications are for. Oftentimes, I will tell the child that a lot of children, for example, a child with ADHD, that a lot of children have brains that are wired differently. and they need a little support. So in order to support that function and to help you be the best version of yourself, we're going to start you on a medication or a pill or a liquid that can be called as a focus pill or a focus liquid for some 7 or 8-year-old who will not understand what stimulant means. And this is going to help you really focus and do well in school and be the best version of yourself. And you're not alone in this. There are 11 children out of 100 who get diagnosed with this and they need help for it. It's kind of like when your dad or your grandfather or grandmother are diagnosed with high blood pressure and high blood sugar, and they need medications to fix the blood pressure and blood sugar. Sometimes some kids need a medication to help them so they can be healthy and they can have healthy minds and healthy brains. And this seems to help. Also kind of adding that this is not your fault. It is not your personal fault. It's not your family's fault. It was just how your brain was wired. But thankfully, we have treatments that are available to fix that underlying issue so that you can be the best version of you. Any questions about that? Okay, moving on to the next questions. What are the early signs of mental illness in children? Now, mental illness is a very broad topic or a very broad category. So amongst mental illness, we can look at some of the broad categories. Some of the categories like what we call as internalizing disorders, known as depression and anxiety, or externalizing disorders that may present like behavioral problems, aggression, self-injury, even ADHD. You must have heard the term ODD, oppositional defiant disorder. Then there are other disorders like bipolar disorder, psychosis, which tend to be less common in children, but more common in older adolescents. And then there is the autism spectrum disorder, which the prevalence is increasing year by year because of the increased rates of diagnosis and increased awareness amongst families. So the early signs for all of these issues are going to be different, but in briefly summarizing, it's very important to rely on changes in mood, behaviors, and functioning of your child overall. You know your child the best, and you know they are a certain way, they function a certain way, they act a certain way. When they get upset, they say certain things. If you're seeing that there's a change in their mood and behavior, and then it's something for you to pay attention to. That might be the time to sit down with your child and talk about, is there anything going on in school? Is there any concern for bullying? Is there any recent trauma or loss or any kind of stressful thing going on that might be impacting their mood and energy level? It is also a good time to maybe touch base with their school and have a good relationship with the teachers to see how are they functioning in school, what is going on, have you noticed any change at all? So for some of the early signs of depression could be a child losing interest in things they like to do, them withdrawing, them being more irritable, sad, or tearful, them being very, very, having negative thoughts, negative, self-esteem, and then making statements when it's very severe about, I don't want to be alive, I don't want to live. This is associated with changes with eating and sleeping, and then you see a gradual decline in functioning. The grades will be going down, the school attendance will be going down, and they will not be functioning very well. So those are some of the early signs of depression, and gradually progresses. When it comes to anxiety, anxiety can present in 2 different ways. One form, and these are very commonly seen, anxiety is one of the most common things that we see. Anxiety typically may present in a child as headaches, stomach aches, difficulty breathing, anxiety or panic attacks where they feel like their heart is going to stop or pass out, really having a hard time going to places that make them anxious, could be some social places, and a lot of avoidance behaviors. So this is one manifestation of anxiety. The other manifestation of anxiety that we see very commonly in kids who are not able in tune or not able to verbalize how they're feeling, especially in those on the spectrum, is outbursts, behavioral outbursts in children, behavioral problems, them going from 1 to 100 in a second, and yelling, screaming, sometimes being physically aggressive or self-injurious. That can be a cause, or that can be a sign of anxiety as well. It takes a skilled child and adolescent psychiatrist to tease apart if it's anxiety or if it's something else. So these are some of the early signs of anxiety. Talking about autism spectrum disorder, the earliest you can diagnose is anywhere from 2 years to 4 years. The early signs are a definite social issue, that they're not able to interact reciprocally in a typical manner. They have difficulty with eye contact, social communication, sensitivity to touch, sound, textures. They may not have as much empathy as your other kid or other typically peers. Speech delay, not having as much speech as much they're supposed to have by 4 or 5 years of age can sometimes be a very early indicator of being on the spectrum. When it comes to other diagnoses like ADHD, and there are types of ADHD, the combined type has both the inattention component and the hyperactivity component. And that is relatively easier to diagnose because hyperactivity is visible to everyone. You can see that there is this one child who's not able to sit in the chair, who has a hard time focusing on one task. They need to go from one task to the next. They really have a hard time waiting. They're jumping in conversations all the time. They're just bouncing off the walls, and there are gradations of it. In order to be diagnosed with ADHD, we have to have these concerns in multiple settings, which means you're going to notice these concerns at home. You're going to also notice them in the school setting, which is why collaborating with school, getting feedback from them would be super, super important. Sometimes another subtype of ADHD is inattentive type of ADHD, where you don't have the hyperactivity component, but you do see the genuine difficulties in paying attention, following multi-step directions, organizing, and these symptoms can start early and get in the way of schoolwork, and they may have a hard time doing schoolwork. So it's important to recognize these and at least start with the pediatrician to see, okay, there are concerns. Some pediatricians may feel comfortable diagnosing and treating these conditions. Others may refer you to a child and adolescent psychiatrist. Then there are conditions like bipolar affective disorder and psychosis. And these conditions are not very commonly diagnosed in children, but they can be diagnosed around later adolescence, anywhere from 16 to 18 years of age, and there are more complex problems. So ultimately, any change in mood from baseline, anything that is out of the norm, any complaint of hearing voices, seeing things, not sleeping for nights together, still having a ton of energy, that sounds like mania. And mania is one of the two polarities of bipolar, because bipolar means they have episodes of depression and they have episodes of mania. Again, this has to be evaluated by child psychiatrists, a very complex diagnosis to make. So these are some of the common illnesses we deal with, and then some of the early signs. But any change from baseline in mood, behavior, activity level, sleep, appetite, and you're seeing a drop or a decline in their functioning, reach out to the school, see if they're seeing the same things, connect with the primary care, initiate an evaluation by a child psychiatrist. Any questions about that? Okay. The next question is 16 too young to explain absent fathers in severe PTSD depression? I actually don't think it is too young to explain absent fathers in conditions like severe PTSD and depression. Think even younger families with younger kids from 4 to 6 to 8 years, where the dad is uninvolved or has left the family and the children are not getting to see them and they're feeling abandoned. It is actually very important to, educate them or let them know about what is going on. to give them a control narrative so they are able to process this over a span of time. Sometimes it is the best way to do that is to get them into therapy. If something like this has happened, this is clearly traumatic, it can be perceived, and it is abandonment, and that can affect their adjustment through the rest of their life. Then the earlier they are placed in therapy to process some of this, to understand the narrative, the better and the more well-adjusted they will be. So I think 16 is not too late at all, even for parents or families going through divorce, for example, where the child is primarily going to be with the mother with very limited supervised visitations with dad. I think the element of counseling and educating and telling the correct narrative to the children and emotionally supporting them during this time, telling them what is actually happening, would be important. And that's where the therapy should be introduced. Any questions about that? All right. What age ranges do you think will develop the most trauma due to the US politics? Now, that is a very tricky question. A lot is happening. It's constantly changing, very dynamic. I would say what is happening currently and the current climate has the potential to influence children as little as the school going age. Because what is currently happening has the ability to influence children from certain families who may then go to schools and say things that can be constituted as bullying or making inappropriate remarks that can impact the mood, anxiety, and other symptoms for other children, making it hard for them during school. So I think it starts very, very early and goes on much, much later across the span. I wouldn't say the only age range that might be spared is probably the first 2-3 preschool years at this point. Any questions about that? All right. Then there was a very important question, was what is the best way to support my child emotionally? First of all, understanding that we as adults, even though if we are not going through any significant levels of anxiety, depression, any adjustment problem to any major stressful thing going on, we all go through the motions. We all have emotional fluctuations from a day-to-day basis. If something stressful goes on in life, our mood reacts to that, our behavior reacts to that, and we all handle that differently. The same thing happens with children, and at much higher intensity depending on how old they are. And it's very different how the teenagers or the adolescents handle emotional issues compared to the younger children. For the younger children, you may see a lot of behavioral problems because they're feeling something emotionally. You might see that they are withdrawing. You might see changes in their activity level, a different sign for the younger children. So whenever you feel like something is off, they're not acting like their usual self, it is good to set aside some time to check in with them and say, I've noticed that you seem a little worried. Are you worried about anything? What is going on? And just doing what we call as emotion coaching. If they're forthcoming about what is going on, helping them understand that it is okay to feel that way. Sometimes some parents may have anxiety and they may not be able to see their child anxious. They might have a tendency to shut down their emotion. No, don't cry, because it makes them anxious. But that is also causing their emotional shutdown, and we don't want that. We want to encourage expression. We want them to feel like it's okay to feel sad sometimes. These are normal emotions. It's okay to feel worried sometimes. And what can you do when you're feeling this way? So emotion coaching is a technique where the parent will check in with the child and basically just ask about what has been going on, what started it, what triggered it, what emotions are you feeling right now? Are you feeling sad, mad, angry, what worried? And helping them talk through it and then working through that. And just that support to allow them a platform where they can open up and talk about what has been causing a particular emotion for them is a huge deal. And over time, they will learn to internalize it. So when they're adults and they are feeling sad or mad or anxious or worried, they have learned to work time that it's okay to feel these emotions. Oh, this is how I'm feeling, and this is why I'm feeling it, and that's okay. And this is what I can do to come out of it and not let it take over my day, because it's just an emotion at the end of the day. So not shutting down emotion, allowing for expression, having that special time. And what will allow for kids to be able to open up with you is if you make sure. It's really hard, you know, with everybody homeschooling, with busy schedules and everything, that you continue to have special time with your child, whatever it is, something that results in a child-led play where they decide what they want to play and you're just playing with them. And that can be a great way to have that reserve where you're able to have that excellent relationship with them, where when they're in trouble, they're not scared to come to you. They're happy and comfortable opening up to you. So I think that's very important. It can be different for adolescents and older teenagers, as you know. Sometimes they don't want to talk. A lot of parents say, is my teenager depressed because they're spending all the time in their room? They're just on their iPad or talking to their friends or playing on the Minecraft. A lot of teenagers do that because that is the age where they're moving away from spending too much time with their families to developing a sense of identity and developing a lot of social connections, friendships, and navigating that milestone in their life. And that is kind of typical. So sometimes they might have very intense mood swings, even though they don't have a major mental illness, just as a part of the teenage years. Just letting them know that you're there to speak with them, to be available to them, to support them whenever they want to talk, whatever is comfortable. If you ask too much or push too hard, they might shut down, withdraw, feel like you're kind of being a helicopter parent. If you don't say that you're there, you know, you've noticed that, you know, okay, I think you're feeling sad or you look a little different, a little off, just know that I'm here for you and I'm here to talk to you whenever you want and whenever you're ready. Even this kind of communication allows them to know that you're there, and they might come to you, or they might politely say no, but either way they will appreciate that you're there and you're noticing and you care. So the strategies will be different for younger kids and for older adolescents. Any questions about that? Okay. Are there concerning behaviors that people overlook thinking it is just kids being kids? Certainly. I do think this starts very early because any behavior, as we say in the child psychiatry terms, has a function. It could be for attention seeking, it could be for something else. So we want to understand what the function of a behavior is. Sometimes some kids might fixate on certain things or not want to follow rules or lie. And even though they're young, even though they're 6 or 7 or 8, or steal, it is, if there is not a consequence, if we let it go, then it might result in a pattern that there was no consequence for it. So any kind of negative kind of behavior has to be brought to their attention. There has to be a conversation about it in a firm voice, but not yelling, screaming, because all of that will not result in any proper action or any impact on the actual behavior. And there has to be a consequence for it. So if it's a 7-year-old stole a credit card, or an 8-year-old stole a credit card from mom's purse and purchased a video game, then it is still considered as stealing, and there needs to be a consequence for it, a conversation about it. The same goes for lying. If we think, oh, they're only 7, they're only 8, We can just let it go, see if happens again. It can result in the behavior just consistently happening over again, or it may not happen again, but we need to set it right the first time in a firm way and a consistent way. And it's important for all the family members to be on the same page about it. Any questions about that? How early can a diagnosis for disorganized brain with seizures be detected in very young children? Very, very early. I mean, seizure disorders is very commonly diagnosed ranging in infancy onwards. There are certain kind of seizures that are very, very obvious, like there are actual movements that can result in the diagnoses. There is alteration in sensorium, change in alertness, arousal levels that can make it easier to diagnose. But a lot of times in kids, they may have something like absence seizures, where they're actually just not there for a few seconds to a minute, that they completely checked out and they have no recollection of what happened during that 30-second or 1 minute span, but they may not actually have any movements, or they did not lose posture or control of their body. So seizures are very commonly diagnosed early on, starting infancy, and absence seizures tend to be a very commonly diagnosed condition. If there are any such concerns, starting with a pediatrician and getting a referral to a neurologist is the best next step. Any questions about that? So the next question is, how does a doctor identify the difference between ADHD and bipolar? Now, that is a very, very good question, because these conditions can have overlapping symptoms. The diagnosis can be fairly confusing, which is why in case of a child and adolescent, the diagnosis should be made by a child and adolescent psychiatrist. The difference, let's start with the difference in the prevalence, or how common they are. So in children and adolescents, ADHD is far more common than bipolar. Bipolar is under 2%, 1 to 2 out of 100, as opposed to ADHD being anywhere from 10 to 13 out of 100. ADHD, and we touched upon this briefly, is like a chronic pattern, a long-standing pattern of either hyperactivity, difficulty paying attention, difficulty organizing, difficulty following multi-step commands, difficulty waiting for their turn. There are DSM-5 criteria, which is our Bible for making a diagnosis, where 6 out of 9 criteria have to be met. And it's a diagnosis that a pediatrician can make, or a psychologist can make, or a child and adolescent psychiatrist can make. So these symptoms have to be present in multiple settings. They cannot just be present at home or just be present at school. They have to be present in multiple settings, and they have to interfere in the ability to function, cause some significant academic problems. So that's what ADHD is. Bipolar, on the other hand, is less common than ADHD in children and adolescents. And bipolar, by definition, means bi. There are episodes of depression and there are episodes of mania. Both of them happen from time to time. True bipolar happens in later adolescence as opposed to sooner. Just being chronically irritable does not mean you have bipolar. Just having some difficulties in sleep does not mean you have bipolar. So for bipolar, they have to have one episode of mania or depression alternating with mania in whatever pattern. For mania, the key things to remember are there is a decreased need for sleep. When I say a decreased need for sleep, it means you're not sleeping at night, but you still have a ton of energy during the day. And this has to go on for several days. Somebody who slept for 2 hours last night, but crashed during the daytime, does not constitute mania. Somebody who slept for 2-3 hours and this went on for 2 days only does not constitute mania. So it has to go for at least 4 days where you only got 2-3 hours of sleep, but you still have a ton of energy. And this is outside of anybody, without using any drugs or alcohol, because that can certainly induce these kind of mood episodes. So this is one of the key symptoms for mania. The others are change in mood, either irritable or grandiose, meaning really elated, really happy for no particular reason. People who are in mania start making impulsive, reckless things. They start doing impulsive, reckless things. They start overspending. They start over socializing. They have a lot of grandiosity or feel like they are special in some way. And then when it progresses in severity, it can have a lot of psychotic symptoms where I believe I'm the president of the country or I'm a famous pop star, and they're actually not functioning and need hospitalization. And the other polarity of it is depression, which we have talked about, where there's sadness or irritability, changes in sleep and appetite, tearfulness, real irritability, negative thoughts, suicidal thoughts, and bipolar has to have both of these, depression and mania episodes. So these are different. ADHD, these symptoms stay the same, unmedicated all the time, has to have in multiple settings. Whereas in bipolar, you have episodes of depression or mania, and you in between, you could be just fine. When you're not in an episode, you could be just fine. And these episodes look very different. Any questions about this? Okay. So the next question is, how is COVID affecting children's emotions, PTSD, and ability to learn, and how can we help them? COVID, as you know, is taking a huge toll on everybody, entire families, children, adolescents, everybody. It definitely has now with the schools opening up, it might be another game, but for the last 6 months or so, children are dealing with a lot. There has been a complete change with respect to their levels of socialization, school life. Everything has changed as they knew it. Any kind of outdoor activity or fun that they could use or indulge in on the weekends to kind of reset for the school week is taken away. Socialization, everything was taken away. So huge impact. Definitely, I'm seeing a lot of surge in anxiety. I'm seeing a lot of surge in depression. I'm seeing a lot of crisis calls for suicidal ideation, behavioral problems, self-injurious behaviors, as well as academic issues, because for a lot of kids, they are just not able to function in the unstructured environment of the home. It's very hard to keep up with these Zoom or remote meetings with parents who are also supposed to be working full-time, taking care of all the responsibilities and homeschooling a bunch of kids in the home. So definitely I'm seeing a surge in mental illness in the past 5 to 6 months due to everything being taken away. For those who are returning to school, again, I'm seeing a second surge because people or children who are now adjusted to following that routine at home, those with anxiety, are having significant anxiety about returning to school or transitioning to school. So we're seeing a lot of anxiety, behavioral issues, not able to keep up with school, for those kind of children and adolescents who have a lot of anxiety. The same is happening for those children and adolescents who have a diagnosis of autism spectrum disorder, because they also have a very hard time transitioning. So COVID, we have seen a huge surge in mental illness. This does not take into account the parent caregiver burnout as a result of the increased responsibilities that have now been imposed upon the parents. And sometimes that burnout can take away from them to be, as patient with the children as they can be, because they're going through their own problems, keeping up with school, home needs, their own jobs. So definitely it's very important to really be in tune with your children, adolescents' emotion, mood, behavior, see if they need additional support right now in school or otherwise through therapy. Do they need to see someone? And also being in tune with your own self as parents, you have to take care of yourself too. It's kind of like the analogy that I use of, if you're in an airplane, the first thing you're told is the oxygen pressure drops, you put the mask on yourself before you put it on a child. It's important for you to take care of yourself before you can take care of the whole family. So if you're feeling burnt out, just stay in tune with it, try to recognize it, see what you can do. Sometimes even 1 to 2 hours of self-care per day can do wonders. Take in turn with your partner can do wonders. So just being in tune with that is really important. How you can help them during this pandemic is with the schools reopening, maybe that'll be a little bit of respite to everyone, but having some normalized activities that you can still do with your children. This pandemic has changed life as we know it. It has changed our whole perspective as a society. But definitely trying to do some activities that normalize their routines. There are some safe things to do. Going on a hike, going on trails, just walk around the block. Things that you could never imagine doing as a family because there was no time. The kids were in school and you were at work. The only time that was there was on the weekends. Now you have the ability to do things that you did not have, like maybe do a art project together or something together that they will appreciate. Knowing that this thing is coming to an end and there might be a time in the future where you look back and say, oh, wasn't it nice when we didn't have to spend all of this time transitioning kids back and forth to school? They were getting their education at home and we had our time as a family and we could do things together. So there are some positive perspectives that the pandemic has offered that we can try to make most of as well. The other question that I have here is, how young is too young to diagnose and medicinally treat a child with behavioral disorder? We have referrals, even, I mean, there's something called as early childhood treatment clinics where children can have behavioral problems starting 2 or 3 or 4 years of age. And typically these kids have behavioral problems because they have other diagnostic possibilities. The bigger one, like we discussed before, was patients or kids on the spectrum, that they tend to be diagnosed anywhere from 2 to 4, but a lot of them may be even diagnosed much later because they were higher functioning and they were not diagnosed in time. So even from 2 to 4, a kid who has a speech delay, does not maintain eye contact, has textual issues, behavioral issues, can be diagnosed. The same goes for ADHD. ADHD can be diagnosed anywhere from 5 and 6 because you see a lot of hyperactivity, impulsivity, behavior. It may present as a behavioral problem because there is so much impulsivity, hyperactivity in multiple settings. And it's not uncommon for us to start treatment for severe ADHD starting 5 or 6 years of age. Of course, it has to be at much lower doses. It has to be like carefully monitored because they're more prone to side effects. But sometimes it is necessary because the ADHD is presenting safety concerns. Other things that can present early on is anxiety, bad nightmares, stomach aches, headaches, not able to talk to anybody outside of the family, avoiding certain places where the family goes on to. We definitely encourage starting with therapy, but sometimes the severity of the symptoms does not allow them to benefit so much from therapy. And we have to jump to medication, but also offer therapy in combination with medication. Any questions about that? The next question is a very important question. How can the school and the pediatrician have more dialogue? I think this is a very important area. And as child psychiatrists, I think it's very, very important to be in close contact with the child's school because a lot of time is spent in school. A lot of time is spent. And a lot of these symptoms impair the ability of the child to function in school. So for me as a child psychiatrist, it is my job to make sure that the school is offering the support that the child needs to maximize their functioning, to be the best version of themselves. Public schools offer plans like individualized education plans, and it's mandated. It is mandatory for kids with disabilities to have the support from school. They offer a lot of services like whatever is needed, speech and language therapy services, individual therapy, functional behavior analysis, OT, occupational therapy, sometimes an aid depending upon the level of symptoms, or a different classroom setting, maybe a behavioral classroom setting for a kid with autism who has a lot of behavioral challenges in a bigger classroom with a lot of kids. So it's very important to first understand that the school is providing the kind of setting that is optimal for the child. They are supporting the child with an IEP and a 504, and then also to see if the accommodations that they're providing as part of IEP and or 504 plan, are they optimal? Are they at the level they need to be? Do they need to be adjusted? And that's where our opinion really counts. As a pediatrician, we certainly do this and need to do this as challenge adolescent psychiatrists. As a pediatrician, though, not sure if that's done regularly, but it should be. For example, any kind of diagnosis and treatment requires feedback from school. For a diagnosis of ADHD, we do need the school teachers to return those rating scales that tell us, okay, the symptoms are getting better, so the symptoms are responding to treatment. We don't need a dose adjustment. Because by the time they're home and the stimulant has worn off, the parent ratings will be elevated. It does not mean that treatment is not effective. It just means the stimulant has worn off. So there needs to be very close dialogue with the school. Have the family sign a release to school and communicate if something is not right, something is not going how and where it should be going. Any questions about that? Next question is, how will I know if my child has inherited my mental health diagnoses? So different levels of diagnosis have different inheritability rates. For example, ADHD is highly inheritable, like strong family history of ADHD, great chance it'll likely be passed on to your kids. Whereas depression, anxiety, mood disorders may be just a 10 to 20% chance. So every diagnosis is different, but as a parent, you know what the signs were for you, early signs, and what are the signs of when you're having an episode and what did it look like for you. So it can go either way. Either you're really hypersensitive to what may be somewhat of a typical fluctuation for your child, just because you don't, as a parent, want their diagnosis to be missed or delayed. So in that case, it's important to kind of get feedback from other people who surround their child, the other parent, other caregivers, tutors, teachers, when it comes to like an ADHD diagnosis. Or the other piece of it is that there are these signs that you're seeing these intense mood swings, or you're seeing deep symptoms of depression or high levels of anxiety as you were. And that is the time to at least initiate a dialogue with a pediatrician and start with therapy if symptoms are mild, and keeping an eye on them. And if they do get moderate to severe and start interfering with their ability to function, then initiate a conversation or an appointment with a child and adolescent psychiatrist. Any questions about that? So the next question is, how do you pick a competent child psychiatrist? So that is a tricky one. I always tell everyone, just finding the right doctor for you, it is kind of like picking the right shoe. That you may have some of the shoes with the best brands, with the best, everything, everybody loves them, but somehow you don't love them. It doesn't fit you. So it is a goodness of fit, absolutely a goodness of fit. The most important thing is the relationship between you and your doctor, your comfort level with the doctor. Do you feel you're heard? Do you feel they're taking care of your needs? And is there that ongoing dialogue back and forth happening? And that you cannot decide or just defer just based on research, just based on Google research, just based on talking to someone. So one thing I find that has been very helpful for family is hearsay. You may know a friend or somebody else who saw a doctor that they really liked, and that your tastes match with their friends. So maybe you could try that doctor out to see if it is a good fit for your family. It may or may not be, but I would say either way, going through Psychology Today, looking for Google search for doctors in your area for treatment of particular disorders, we can't solely rely on just Google reviews. There may be some doctors who have hundreds of patients and do a great job, but they might have just 2 Google reviews, or they might have just a 2.5 star because the one patient who was unhappy out of the thousands they saw wrote a really bad review. So we can't really rely on just that, but basically getting a list of the doctors, starting with someone, preferably if somebody you know and are close to has used somebody in the past, has sought somebody's help in the past and it worked well for them, hearsay, that might be a good place to start. But ultimately it is give the doctor a few visits to determine if it is a good fit or not for you, because they could have the best reviews, they could have the best resume, but it may or may not be a good fit for your family. So that is a very important part to remember. What is a good technique to help children recover from parental alienation? I think we did talk about that a little bit. It is recognizing as a parent that this will be a hard thing for you to talk about, that this is an anxiety provoking topic for you as a parent. So a lot of times when we feel anxiety about something, we tend to avoid it. We don't want to deal with it. It causes us anxiety. We don't know what to say to the child. And if that is the case, then really introducing therapy early on to address those feelings, to understand what should be your script for the child. What are you supposed to tell the child about? Where did the dad go? Why are they suddenly not seeing the dad at all? Or why are they suddenly not seeing the mom at all? Where did they go? And allowing child to work through that support between you and the therapist. Sometimes a parent may not know what to say and what is the right way to do it. That is where seeing a therapist really, really helps to allow you to have a narrative that you can work through with your child. And you may find that there's a lot there that they're holding in, they're dealing with. And if you do see some changes in their mood, anxiety, energy levels, anything that's off, it may be time to get them into therapy. Sometimes younger kids can work through these anxieties through play. They might get it out through play. So it's important to get them into play therapy for younger kids. And for older kids, they can initiate the individual therapy or maybe have trauma-focused CBT with the CBT specialists. Definitely important to recognize and address. Any questions about that? All right, then one more question that I have here is family intervention when a child has been diagnosed with mental illness important? Absolutely. Family intervention is very important. Anytime I work with any children and adolescents, I'm essentially working with the whole family, because oftentimes there are things going on in the family that reflect on the child's behavior and functioning, and that can make the child a problem, and the real problem might be in the family dynamic that we need to address. So it's very important to recognize that when we are working with children, we're actually working with the whole family. We have to assess, are any of the family members going through a mental illness or hard time or through burnout, and how is that impacting the child's ability to recover from this? Are the communication dynamics optimal? Are the channels of communication open, or do they need to be opened up? Assessing those patterns and working with them is very important to make sure that the child and adolescent is getting a well-rounded treatment. So for any family, working with any child of adolescent, for children, I typically start session with the child and the family together. With an adolescent, I start with the adolescent, but in the end, I do always include the family. A very important part of the treatment. Any questions? So I think I did address all the questions that had been selected based on the votes, and I can take a few more.
Dr. Nisha, would you like me to read those in the chat?
That'll be great.
Okay. Sarah Bashford asked, if someone calls 911 and reports a suicidal teenager, what does the police do?
Typically, the police will show up to their home, and if it's an actual like suicidal ideation with a plan and intent, then they might do several things. They might place the patient on a hold if they're not willing to come to the ER. But if they're willing to come to the ER, they might bring the patient and the family to the emergency room for an evaluation by psychiatry and the need for hospitalization.
Thank you. Nora McFadden asked, are there resources to reach out to and educate children about mental illness if they have a parent with an undiagnosed mental illness and the family is unaware, not acknowledging that the parent has an illness?
Yes, I think the biggest resource I would say is NAMI. I recommend or connect my families and patients to NAMI all the time. Obviously, things are limited because of COVID right now, but NAMI offers a lot of resources in terms of groups, support for families, educational sessions, which is a chance for the family members to get some support, and connect with other families who are working with or living with a family member with a diagnosed or undiagnosed mental illness.
I think there's no questions. Any further questions?
All right. Well, thank you so much for this opportunity to answer these important questions. Any one of you is welcome to reach out. My email is nishawarikoomd@monarchpsychiatryca.com. And Eugenia will be happy to share my contact information with you.
Yeah. Thank you so much, Dr. Nisha Warikoo, for taking the time from your busy schedule to be part of our conference. And thank you to all our attendees for attending.